So my talk is going to be on the effect of physical activity, sport, and exercise on gamete quality. This is a little bit new to me, as I have always mainly talked about sperm quality, but now we will also be including the effect on oocyte quality and female athletes. I declare that I have no conflict of interest. And before we can actually assess and get into the effect of physical exercise on both sperm and oocyte quality, it is important to have some prior considerations so that we have some basic concepts that are needed to understand the relationship between exercise and fertility. I will also talk on the difference between physical exercise and physical activity, as well as training. And I will move on to describe important variables that relate to physical exercise and training. And then we will move on to what is known about exercise and the reproductive system relationship. We will continue with some recent research that has given some evidence on aspects such as intensity, volume, and modality. And then I will move on to a reflection on whether exercise is always bad for sperm and oocyte quality. And finally, I will end up with some take-home messages and conclusions and challenges. So the main question, and this relates to even overall health, is exercise health? We know in the last years there's a tendency, or it's been shown that we are going into a more sedentary lifestyle, and that is actually a modifiable risk for different diseases such as cardiovascular disease, obesity, cancer, hypertension, etc. However, and it has also been proposed that exercise intervention can help to avoid these problems and even to revert that. The thing is, like, sometimes, and there has been a change because some of the prescription of exercise would be vigorous exercise, and in the last years it has actually been changed from vigorous exercise to a more moderate type of exercise. This is because vigorous exercise can actually induce problems in the overall health as well as the reproductive health. So the tendency now is actually to go into moderate exercise, and we will see exactly what happens. So the same thing that happens on an overall health, because all the systemic processes, they're influenced by the exercise, either volume, intensity, modality, and the inherent characteristics of any type of exercise. They will also have an influence on reproduction. So what's the difference between physical exercise and physical activity? Well, the main difference is connotations in how they're performed, and also the requirements and the goals of such activities. For example, physical exercise, physical activity refers to activities that just get your body moving and they have an energetic expenditure. And whereas exercise is actually a form of physical activity that is planned, is structured, and it's done to improve at least one aspect of physical fitness, whether it is strength, flexibility, or aerobic endurance. And when we talk about training we mainly live for people who are actually athletes, that their goal is actually to compete. Now, with regards to the different variables, it is important to have some basic concepts. And this session was supposed to be after Professor Hackney, so I will not give a lot of detail, but just to introduce you to those variables, because they are key to understand all the research that has been published and that might be published in the future. So these variables are intensity, volume, frequency, density, and type of exercise. So that you understand, intensity is really how hard the athlete perceives the exercise. So it's a qualitative property of the physical work. It's normally expressed as a heart rate, or percentage of a maximum heart rate, percentage of a maximum oxygen uptake, or as a percentage of what it's called one repetition maximum in strength sports. With regards to volume, this variable deals with how much, so the amount of physical work, so therefore it's a quantitative property of the physical work that is done. Frequency refers on how often this activity is performed, and density deals with the relation of the time or duration of the exercise and the duration of the rest or recovery between the exercise. And this can be in the same session or between different sessions. And finally, the type of exercise, it might be either strength or endurance. So strength, I'm not going to be really talking much about strength because strength deals with muscular adaptation, so mainly it's to work with resistance or weights, and the goal is to actually improve muscle mass and muscle strength. And because this type of exercise sometimes is associated with anabolic steroid use, I'm going to really not mention much about it. So I will deal mainly with endurance exercise, and this endurance exercise is a type of exercise that will induce many central and peripheral adaptations, mainly in the cardiovascular system, and also in the processes it will deal with mainly using fat and glycogen, so it has a lot of oxidation and catabolic activities related to them. Okay, so let's move on now to what has been described until now about exercise and the reproductive system. And we all know that there are many agents that will disrupt the endocrine and the reproductive homeostasis. We know about many compounds, mostly chemicals, but also hormones. And I would like to include exercise as a potential disrupting agent, because an extenuating physical exercise may actually provoke alterations on the reproductive system. And these alterations, they have been described since about the mid-80s, and there has been a lot of research. We will also see that this research has been a little bit controversial, so there's still a lot of things to find out about this relation between exercise and fertility. So some of the first studies were actually done on female athletes, and up to date it has been reported that about 50% of the athletes will show exercise-associated menstrual disturbances. These menstrual disturbances, they will vary in degree and severity, and they can vary from hormonal decrease, delayed menarche, oligomenorrhea, amenorrhea, inadequate luteal phase, and anovulatory cycles. As I said before, these studies have been conducted since the early mid-80s. Okay, and I would like to point out with regards to elite female athletes, as I said, about 50% of them show exercise-associated menstrual disturbances, and we can see this is actually an image from Mallinson and colleagues from 2016, and we can see how there's an increasing severity, and they go from either subtle subclinical menstrual disturbances to severe clinical menstrual disturbances. So they may go from regular ovulatory cycles, go through luteal phase defects, short or inadequate, anovulation, oligomenorrhea, and amenorrhea. And in this image, we can actually see it's a comparison between either sedentary people or athletes. So we see most of the people, of the normal people, sedentary people, will have ovulatory cycles, whereas only less than 50% of the athletes will have regular ovulatory cycles. For the rest, we can see either anovulatory cycles or luteal phase defects, whereas in sedentary subjects, only luteal phase defects have been reported. If we take this a little bit farther, we see that the sedentary people, those showing luteal phase defect, it's been shown that it's actually an inadequate luteal phase defect. Whereas if we break down the luteal phase defect in the athletes, we actually see a compound of inadequate luteal phase defect, short and inadequate luteal phase defect, and short luteal phase defect. This other image by Gibbs and colleagues from 2016 shows the importance or the relationship between chronic energy deficiency and the exercise-associated menstrual disturbances. And this has mainly been assessed in athletes or female sports women that participate in sports that require a special biotype, meaning they have to be lean and they have to have muscle, but they require a certain body weight and a certain type of body for that particular sport. So we may see especially these effects taking place in runners, cyclists, swimmers, but also, and maybe even more so, in ballet dancers, figure skaters, and gymnasts. So in this chronic energy deficiency, we see that there is a disruption in energy and metabolic homeostasis, and this is referred by a decreased resting energy expenditure, so that is the energy expenditure measured at baseline, lower triiodothyronine, decreased leptin, decreased insulin-like growth factor 1, and an increase in ghrelin, peptide YY, and growth hormone. So what happens here in the end is that there is an exercise-associated menstrual disturbances because there's a suppression of both growth and reproductive function in the need to compensate and to keep the vital bodily processes so that these are protected. So these are thermoregulation, cellular maintenance, and locomotion. So what happens in these athletes is that we need to sacrifice the reproductive and sometimes even the growth in order to keep those vital processes. So in this case, if we reach to these exercise-associated menstrual disturbances, as I said before, we can either reach a subclinical or a clinical significance. And if we reach clinical significance, there will be a functional hypothalamic amenorrhea or oligomenorrhea. This image here just wants to express that we can go from a healthy to a subclinical or to a clinical aspect in this relationship, with low energy availability being one of the main issues. As I said, these type of athletes, they need to have a special type of body in order to perform and make a good mark. So this low energy availability, they can be related or not to disordered eating. But they also will present with a low bone mineral density and also with clinical menstrual disturbances, as I have already spoken. Okay, now what happens, so we have talked about what happens in the female athletes, but what happens with women that just exercise? Well, it has been seen that women who are active on most days, they actually have 3.2 times more likely the chances of having fertility problems than inactive women. So exhaustive exercise, even if it's in females that are not athletes, has been associated to fertility problems. And it has 2.3 times the odds of fertility problems versus low intensity. Now, for the lower activity levels, there were no associations found. Also, the results were adjusted for age, parity, smoking, and marital status. Also, it has been shown that there's a dose-response relation of physical activity to delay time to pregnancy in all subgroups of women, with the exception of overweight and obese women. So the authors, Wise and colleagues, they have observed an inverse monotonic association between vigorous physical activity and fecundability. And they showed that this happens when it reaches a certain amount of at least 5 hours per week.
For the last 20 years on the COMET test, our university has
also
set up a sperm company
some
to
authors have
commercialise some of this,
hypothesized that there is a parallelism between the effects of physical exercise in female athletes and the effects of physical exercise on male athletes. And also since about the early 90s, there have been some studies done with male athletes, and they show different. They also show great variety of different effects. Going actually, some of them will show hormonal alterations, some show semen alterations, some others show morphological alterations, and even functional alterations such as erectile dysfunction has been reported. So far what is known is hormonal responses. These have mainly been assessed in runners, cyclists, and swimmers, and semen responses in marathoners, runners, cyclists, and swimmers. And from all the studies, actually, De Souza and Miller were able to establish what is called a volume threshold hypothesis.
So I know we started talking about semen analysis, and of course semen analysis is the gold standard, and semen analysis is the test that is recommended by NICE in the UK, and it's also it's in the WHO recommendations. But
so
I would agree entirely
this just
with
shows
Rebecca that
differences
one thing
with
semen
regards to
analysis
volume
does
of
tell us
training, and
is how
sometimes
many
it's
sperm
hard
you
when you
have
actually
you got
look at
enough
the
sperm
literature,
to do
because sometimes
some
it's not
ART,
very well
but
specified
really
in the
it doesn't
different
tell you an awful lot
articles
more than
that are
that.
found.
It has limited diagnostic value for both male
trying to gather
infertility
some of this
and also
information,
for
we could
its
find
prognostic value for
and
ART
classify in
outcomes,
either low to
even the very
moderate
early
or high
outcomes.
volume. And in
If
the
we
low
look
to
at semen
moderate,
analysis,
we can see not
donor
many
sperm
changes in
compared to
hormones,
that
or
of
even
patients.
if there were
You can
changes,
see here
most
that
of them
really,
were
whether you're talking
significant
about
and
concentration,
clinical, so
morphology, or
not
motility,
really very
there's very little
significant
relationship in this
So
that
some of
separates
some
the
of the
donors from
papers
the
available,
men who are attending
such
for
as
infertility
the one from
investigations,
Ayers
and there's a
colleagues,
very high overlap between
the one
two.
from Griffith and Wheeler.
On the other hand, there's very little relationship between sperm DNA damage and semen analysis parameters. And of course that's exactly what we would hope, because there's no point in adding an adjunct of DNA testing to a semen analysis if it gives you exactly the same results as you can get without it. And the only relationship that we found using the COMET test was a relationship between sperm motility and DNA damage. And that was what we would expect, because motility is a real-time indication of whether the sperm is alive or healthy. Concentration doesn't matter to some extent. Morphology doesn't matter so much. But if the sperm is swimming vigorously, you know that that's a healthy sperm. And so we found a relationship between DNA damage and progressive motility. But if you look at the odds ratios in terms of which one was the better prognostic
to semen, the same discrepancies
fertilization in vitro, you can see that the DNA test is much higher. The odds ratios are much higher than those for motility.
Some other studies show
if semen analysis isn't particularly good, then if we turn to sperm DNA anomalies, we can see that they actually influence every fertility outcome that we have, from poor embryo development to failure of fertilization in IVF, not of course in ICSI, because that's a rather artificial figure, because the embryologist basically puts the sperm inside the egg. A failure to implant in ICSI and post-implantation loss and malformations from animal studies. Increased miscarriage is associated with high DNA damage. I'll talk a little bit more about that later. And childhood health. And I think that's where we're moving to now. Again, that was very interesting what Rebecca was talking about in terms of the outcomes to different specialties are very different. But the outcome that society wants is a healthy child. And as the number of conceptions from ART increase around Europe, and as birth rates drop from spontaneous conception, and so the children who are born as a result of ART become a larger proportion of the population, then it's really important that we're producing healthy children as well as just success within the lab. So in terms of detecting sperm DNA damage, there are 4 tests that are the most popular ones that people use. There's the COMET test, which we've used in Belfast for a long time. There's the sperm chromatin structure assay, which is the daddy of them all. It's been around since 1980. There's the tunnel assay, and then there's the halo test, which isn't really a DNA fragmentation test. It's more a test to tell you whether the chromatin packaging is adequate or not.
When assessing
so
soccer
if we look
players,
at the tunnel,
what they could see was actually that
we don't really have a clinical threshold for the tunnel. And one of the problems is that the tunnel is done very differently in every lab around the world that uses it. Now, a couple of years ago, all of us working on DNA got together in Florence and said that we would really like to take the same semen sample, aliquot it out, send it to all of the labs that were interested in doing it, and do a comparison. First of all, to see how the tunnel compared to the SCASA compared to the COMET, and also to see what the reproducibility of these tests were within the different labs. Alas, that didn't happen. We're now trying to resurrect the idea and do it again, and I would be very keen that we would do this because we'd have a much better idea then on how useful the tests are. The halo test, as I was saying, is really the opposite of all the other tests in that this is a normal sperm because you get this relaxation of the chromatin and the proteins around the nuclear head, and the one here which didn't create a halo is the one which is abnormal. Now when you get you're looking for the absence of something, it's very difficult to know how accurate that is, because if you're looking for the absence of something, it may be to do with your protocol that you didn't actually do it properly. Also, in terms of the actual results for the halo is very popular because it's something that can be used in a lab. The other tests really have to be outsourced because they're much more complicated. And certainly your routine IVF lab is not going to be able to do a SCASA or a COMET test. But in terms of the halo test, yes, lots of people have taken it on board because they can do it within their semen analysis, basically within the lab. But here's one of the biggest studies which was done, and this shows that really there's no relationship between the halo and either pregnancy rates or live births. Here's another study which came out more recently, and again this shows first of all that there is a relationship between DNA damage with the halo and semen parameters, which is again what we don't really want because that just gives us confirmation of what we had before. And secondly, it doesn't show much of a difference between the pregnancy rates or the people who had DNA damage and got pregnant and the people who had DNA damage and didn't get pregnant. The SCASA test, as I was saying, is the daddy of them all. This was developed by Don Edison many years ago. It's a robust test. It has many studies.
This is actually one of our studies, and it was done to assess the effect of intensity.
Needs to be outsourced, so you can send samples off to SCASA Diagnostics, and they can give you a result within a pretty short time.
The training parameter was actually 2 weeks of cycloergometer exercise.
This is some of the results from the
so we were actually looking for the effect
test,
of the maximum
and here you can see that there is a strong relationship between IVF success in terms of pregnancies and also live births,
so there were 2 weeks,
low DNA damage. That's not the case for ICSI. So DNA tests work well for IVF to predict it. They don't work so well for ICSI, and I'll talk about that in a moment.
We had an examination actually of the subjects.
The sperm COMET assay is a different type of test in that all the other tests give you an all or nothing result. So if you put 100 cells, 100 sperm through a flow cytometer or whatever way you measure it, and you get a result of 30%, that means that DNA damage was detected in 30% of the sperm and 70% it wasn't detected, because it's an all or nothing. It's usually a colour change. That's not the case in the sperm COMET test, because what we do there is we actually lysin membranes relax the DNA,
what we
and
did,
because
we
the DNA is
chose
charged, if you put it into an
a
electric
program
field,
in which
then depending
the
on the
subjects
fragment
would
breaks,
pedal
they would
at
pull out
25
into what
watts
is
and 50
like a comet
watts
tail. So
for
that's
3
why it's called
minutes
a comet.
each,
It's just
and
like a
after the 50
celestial
watts,
comet.
they would
And from
increase
the
25
length and the
watts
then
every
you can
2
measure the amount
minutes.
of damage
And
per
that would
sperm,
be maintained
which is
until
different
they
to the
could
other
no longer
tests which show you the
keep
damage
cycling.
per sample.
And afterwards, we did the hormonal and
Some of the
semen
criticisms
analysis.
of the comet have been that
What we were able
it
to
only
find
uses a small
was
number of
actually
cells,
that
whereas the others
testosterone
use
was
many
unaltered.
cells. We've done tests
As
in
we
our
can
lab to
see
show
here,
that it
there was
is
a slight
an adequate number of
increase
cells,
after
and
the
even if
3
you double the
days.
number of cells or triple the number of cells, you
So
still
in
get
the
the same
second
result. So it is a
post-analysis,
robust test.
but it was not significant.
In terms of establishing
And what we
clinical
found that
thresholds,
was
again, we've
interesting
done
was actually that the
some work on this.
cortisol
This was
levels
first
were
of all
going
to
down.
attending for
So
infertility
that's a little bit
investigations,
striking
and we had
because
fertile
cortisol
donors
normally will increase
from a
in
sperm bank.
athletes.
And
So
we found
we
that
just
this sort of
assumed that
cut-off
maybe
point of about
the subjects,
25%,
for some reason,
95% of
maybe
the
were a
donors
little
fell
bit
below
nervous,
this,
or they
but
were
only
expectant
7%
about what they were
of
supposed to do.
the men attending
So
for
maybe
infertility
there could have been a
investigations.
psychological
And again,
stress.
below you can see the sensitivity, specificity, and
Also,
the
there was a
predictive
decrease
values
in
here,
FSH
and the
and also in
ROC.
LH.
So they're quite high
We have to
values,
say that,
suggesting that DNA
except
tests
for
are a useful
cortisol,
addition
all the
to what
hormones
we're doing
return to
in the
their
lab.
pre-testing
This is showing
values.
some of the results using the COMET test.
With regards
and again,
to
all I
semen,
wanted
we
to
were
show you
able
here
to
that
see
was
actually
that the
that
live
sperm
births
concentration
in the men who
decreased,
have low DNA
and
damage
also did
are much
ejaculate
higher than in those who
ejaculate
have
volume.
high DNA damage.
Actually,
That
they
is
both
not the case
decreased,
for
and
ICSI, but it
afterwards
is
they
most definitely the case for IVF.
significantly, almost back to baseline levels.
Again, another paper that we published recently was to look at
That meant
unexplained
actually that
infertility.
total sperm
I know many of
number
you who are clinicians find
decreased
unexplained or idiopathic
significantly,
infertility
and
a
even
real
though it
problem.
rose
You have nothing
almost
to say to the
back to,
patients. The patients
baseline
very
levels,
often
it
go
had
away
not
thinking,
recovered
well, they said there was nothing wrong with us, which of course is not what
And
you said.
with
You said
regards
we
to
don't
type
know
A
what's wrong with you, but
velocity,
actually there must be
we could
something
also
wrong,
see there
otherwise
was
you
a
would be getting
decrease in
pregnant.
this parameter.
Something like 25 to 30% of patients, of couples, get a diagnosis of unexplained infertility, and they don't know where to
Interestingly
go with
enough,
this.
there was a
Should we
big
have
increase in
IUI? Should
type
we
D
continue
velocity.
trying? Should we have IVF? What
And
should we
we
do?
had even
and in a
we
study
even
that we
had to
published a couple of
perform
years ago, we found
vitality
that
testing in
80%
some of the
of
samples
these men
because
had
this
DNA
increase was so
damage.
big and really
Now,
unexpected.
this has also been shown by the
And
SCASA test, but their test
in one
has
of
shown
the
about
8 subjects,
20%.
we could
But there
actually
certainly
find
is an indication
necrospermia.
that in these men with
So there
unexplained
was
or couples with unexplained
this big
infertility,
effect.
DNA damage is a factor. Now, if that is the case, that will change your
And
your,
we could
your,
also see a
treatment,
big effect on sperm
choices.
morphology. There was a big
So
decrease.
one of the things we would worry
and
about
even
then is
though
if we say that a person
the
has high
value
DNA
rose
damage,
in the
will we
second
then go straight to ICSI
post-test,
rather than going to
it
IVF?
did not
And this is
reach-
something that concerned
it
me
did not
personally
go
for quite a
up
long
back
time
to
because it
baseline
seemed
levels.
to absolutely defy common sense. But what
So
I actually think is
other
happening
authors have
is
been
not
studying
that
also
we
the
are using
effect
damaged
on
sperm,
intensity,
but that we're giving the
and,
egg a much
there's
better opportunity to
controversial
repair the damage.
results.
Now, this
Some
was alluded to
have observed
earlier, again, by
decreased sperm
Rebecca.
count and
So when we're
motility as well
talking
as
about DNA damage,
spermatocytes,
and also,
spermatids,
by
and
Victoria,
this
when
is
we're talking
supported
about
by
DNA
also
damage, we're
changes
talking about, first of all, the
in
amount of damage there is in the
hormones
sperm, and
the
secondly, the
antioxidant
ability
enzymes
of
such
the
as
egg to repair that
superoxide
damage.
dismutase
I would
or
love to do some
catalase,
studies on
and
this.
they have also
We've
seen
tried,
an
we haven't got
increased
funding yet, but it's so
malondialdehyde
important to
concentration.
find out if there is
They
a
have
limit
also
that the
hypothesized
egg
that
can
the
actually
greater
repair a certain amount
the
of damage
intensity, the
per
greater
sperm.
the oxidative stress.
Um,
This was
the
actually
reason
done
why
in animal
I
models,
think this is
and of
important
course,
is because there are a couple of
in
things that are
human
different
samples,
between
we can
IVF
really
and
only
ICSI.
assess
The first thing is
the
that the
ejaculates
women who
and
are
not really
having
see what's
ICSI,
going
maybe
on
30% of
at
those
the
women,
testicular
have
level.
got fertile eggs to start with, so they've got, probably got better repair
Another
mechanisms
study
than women who are having to have
done with,
IVF, who have
with
not only
runners
tubal blockages, but maybe
has assessed the
problems with
effect
the
of
quality of
moderate
their
versus
eggs.
high intensity.
The second thing
So
is
moderate
that you're putting the sperm
intensity
in
was
ICSI
described as
straight into the
60%
egg,
of the
sperm heaven.
maximum
So the
oxygen
sperm's just in there all night instead of being in
whereas high intensity was
suboptimal
described
culture
as
media.
80%
And again, we're
of
going to be
this
talking about this
maximum
more
oxygen
this conference,
consumption.
about how important the
And
quality of culture media
this was
is.
actually done
And thirdly,
for
if you
60
think of the
weeks,
difference between
and then
IVF
it
and
was
ICSI,
followed
in
by a low
IVF you've got
intensity
lots of
recovery
sperm
of
with DNA
36
damage.
weeks.
The reason they DNA damage is because
so
they're
this
generating free
study,
radicals. You put
to
an
me,
egg
is
in
actually
with thousands
one of the
of sperm overnight, and what does the egg do? It spends the whole night
main
firefighting fighting because of all these free radicals which are surrounding it. In the other scenario, you've got one sperm, one egg.
And it has
you put
been very
the
well
sperm
controlled,
right
to
into
my
the egg,
understanding,
as I was saying, it's
and it
sperm
really
heaven, but
shows
also
an
from the point of
effect
view
on
of
the
the
long
egg.
term
The egg
of
acts like a
either
critical
low
female. She spends
intensity
the whole
or
night
moderate
pulling together
intensity and
all
high
of the broken necks
intensity.
of DNA
what
in the
these
male,
authors
and
saw
by the
is that
morning
there are
before
declined semen
you have first
parameters,
cleavage stage,
as well
you've got
as
a lot of repair
decreased
done
testosterone
because she's
and
able
free
to focus on
testosterone.
that particular
And not only
issue.
that, but when
And I
they
think
applied
we
at
actually
GnRH, they
back
could
this up
only
with
get a
science if you
blunted
look at some of the
response.
references which
So
I've given you there.
there's a big alteration in the HPG
The other
axis.
thing that's really important is the fact
Also
that there is
recently,
now a
Tatiana
well-established
and Maleki,
relationship
they
between
have
sperm
shown
DNA damage and
increased,
recurrent miscarriage. Now, this is a
interleukins,
very novel
tumoral
idea.
necrosis
And,
factor alpha,
actually, I'm on a task force
reactive
writing
oxygen
new guidelines
species,
for ESHA at the moment
malondialdehyde,
about
and
recurrent miscarriage. And this is the first time the male has
superoxide
ever been
dismutase,
included
catalase,
in
and
such
total
guidelines. We've
antioxidant
always thought it was
capacity.
completely a female
This
problem.
has also assessed
But this
the
is quite
effect of
interesting because
intensity.
now we're
So
able to
it
give
seems,
a new patient pathway
they use
to
high
couples. If
intensity,
they
so
find
it seems
that there's a
anyways
high
that
DNA damage and that's
intensity
what's
has,
caused recurrent
high
miscarriages,
intensity
then they
may
can
have a
think of,
deleterious
first of all, they've got a diagnosis, which is fantastic for them, and secondly, they've got other alternatives because if you look
Also,
at this as
another
an
of the
infertility
questions
problem,
rising
then
is what
there
happens
are other
or
options,
what's
for
the effect
example,
of the
donor
different
sperm or
modalities.
perhaps testicular sperm. And
We
we can talk
performed
about that later if you
one
wish.
study in which we actually had
A
45
new
subjects, and
test has
they
come on
were
board. There are only a
allocated
couple
according
of
to their own
publications
practice.
about it at the moment.
So
It's
this was
looking
not
at
randomized.
neutral comet
And we had
assay, which
16
looks
physically
at
active
double-strand breaks.
subjects,
And of course,
14
double-strand breaks are
water polo
probably
players,
more
and
important
15
in terms of fertility
triathletes.
and outcomes than
We
single-strand
analyzed
breaks
training
because
volume,
the egg can put
and
together
we
single-strand
also
breaks, but
performed
can she
semen
find
analysis.
the double-strand
What
breaks? That's
I
going
would
to be
like you
much more
to
difficult in terms of
take a look
repairing them.
at is three
and
main
of course,
variables
this is just
here,
what I was
which are
saying
different
before, the
between
idea
groups,
that the
and
implications of
they
sperm
make
DNA
sense, of
damage
course.
are not just the
Is
early
the sports
outcomes, but
category,
also the health of
so
future
physically
generations.
active, they were local,
And
so
a couple of
in case that they
good
competed,
reviews have come
they
out
were
of John H.
competing at a
Hill's group
local
about that.
level.
So what patients would benefit from
The water
sperm DNA
polo
testing?
players were
Basically
competing at a
everyone,
regional,
except the ones who are already going to have
level,
ICSI, because
and the
you're not going to
triathletes
change
were
your
competing at the
treatment
international level.
for them, but everybody
So
else
of course
would
that
be
brings
wise
that
to have this
the number of
additional
sessions
test.
per week and the duration of the
The one
session
big
were
limitation
different.
about
So,
DNA testing is
and
you
also
cannot
actually
use
the
the
years of
sperm
training.
that you have used. If you do a DNA
so
test on it, you
this
destroy
determines,
it,
for
and therefore you
example,
can't use
with the
it
years of
clinically.
training,
Now, this is where
the
if Raman
physically active had
microscopy
been
comes
training
in,
for
it
about
will
2
be a
2
huge
years,
step forward
whereas
because
the
it
water
is a
polo have been
non-invasive
training for
test
4
and it will
years,
be able to
and the
measure the
triathletes
level
for
of
8
DNA
years.
damage in a particular sperm.
The number
and
of
then,
sessions
as far as
per
I know
week
it, then
were about
you can use those
3,
sperm
3.5
clinically. So
for
that
the
will be
physically
a
active,
will
5
be
for
a
water polo,
major
and
advance for
almost
us.
10 for the triathletes.
But at the moment, what we're trying to do is develop
And the
proxy
minutes
tests.
for
So
each
a
session,
lot of
the
people
minutes
are
that they were
saying, well, there's a
actually
relationship between
involved in
DNA damage
practicing,
and
it was
and
60
these are the
minutes
tests we have. We've
in
got
the
hyaluronic
physically
acid
active
binding, we've got
versus
apoptotic
90
markers,
in
we've
the
got
water polo
surface
players
charges, we've got IMSI, we've got
versus
biorefringence,
122
and people are
minutes
saying these all have a
for the
relationship to
triathletes.
DNA damage. Therefore, if you do this test, that will give you an indication of how good the DNA is, and
What
you
we
can then
could
use
find
that sperm. At the moment, this is
in this case
not really very well
were
proven.
differences for sperm concentration,
One big
total
study that
sperm number,
I'm involved in at the moment
type
is
A
the
velocity,
Select study, which
type
is a
B
large study in the
velocity,
UK. And
type
what we're
B
looking at is
velocity,
hyaluronic
and type
acid
D
binding
velocity.
to see if there is a relationship between that for ICSI patients and DNA. Sorry, I'm finding it hard to see these because they're so small. Just a few
Also,
things
there was a big
to finish
effect
are
on
the idea that sperm DNA
morphology
damage actually has a
between the
relationship
3 different
with the
categories, so
health
between the
of,
physically active, which
outcome.
showed the
Oh, no, I
highest
haven't got
number of
quite-
morphologically
So this is a paper which
normal
is talking
sperm,
about hyaluronic acid
to water
binding,
polo
and
and
it's some of
triathlon,
the
who
foundational
were
work
barely
that
above
has led to this
4%.
randomized controlled trial that we're using.
And
Again,
this
as I
was
say, the
published
jury's
back in
out, but it's hopeful
2009,
that
so the reference
this
values were
hyaluronic
different.
acid binding may
And
be
here
an
we said
indicator
that
of no
water
DNA
polo
damage, and we
players
can
and
use those
triathletes
sperm
reached
for
both
ICSI.
statistical and clinical
So that's the study that
significance.
I'm talking about if you want to look further at it. Yes, now here's the next thing I think we ought to be doing. As you know, time-lapse imaging is
of
the
these
rage. Everyone has got
modalities,
some
also
sort of
some other studies have been
an
reflecting the
imager
effects on
system in
cycling,
their
running,
ART clinic
swimming.
now.
Even
And
though
the one thing
swimming,
again, as
as I
usual,
have
that we've
shown,
left out
really
is the sperm.
the
What we're looking
studies
at
have
is
been
eggs, we're
conducted
looking
in
at
animal
embryos, we've
models,
got no
and,
idea if there's a relationship between the
there's
sperm
one study that I
and
would
the
like
eggs.
to
And
highlight,
the reason why people
even
have said
though,
that it
as
doesn't
I
matter
said,
is
I
because
was
we've
not going
thought
to
that
deal
DNA
with
integrity
with the
doesn't
strength
matter until you
training,
get
but I would like to
much
highlight
farther
that
on
there's
than
one
an early
study
embryo.
that refers
Again,
the
that is not the
increases
case.
in
There are papers that have come out to show
structural
that DNA,
defects
sperm
induced
DNA,
by
affects
nandrolone
fertilization
decanoids, so
and
that's
right
a
through from
anabolic
early embryo
steroid.
cleavage. So it is something that we could include in time-lapse imaging as well, and I think we ought to. This is a paper that came out from Doug Carroll's group last year in America, and it's showing a relationship between the number of sperm that can be detected as DNA damage between the SCASA, the tunnel, and the sperm comet. You can see with the comet it's about 70%, and the other two are about 15%. So it might be that
it has been observed that in rowing,
imaging with a test, the comet test would be the one to use there.
This is also related mainly
this again
to
is a paper which is very much
of higher training
new,
volume,
novel and exciting, showing that early embryo quality is dependent on sperm DNA quality. I don't know if you're aware that 10 or 15 years ago there was a paper in the Lancet by Pierre Brodie in London
most of them
showing
actually
that there was no relationship between sperm DNA
so
and early embryo
with regards to
quality, and people have taken that on board. Obviously, it was such a good journal it was published in, but new data is now making us think quite differently about this.
What happens as a result
many people, as you know, are very critical and unsympathetic to infertile couples because they say you brought it on yourself.
Also, some studies have been
either you waited too long to have children, or it's something to do with your lifestyle. And there's absolutely no doubt that there are many lifestyle choices in the 21st century which do not support good fertility.
And the triathletes,
but to get back to what Victoria was saying, oxidative stress seems to be the common
with regards
factor,
to training
volume,
also some
and if that's the case, then if we were to change our lifestyle, would we be able to protect our DNA, sperm DNA from damage? And again, I'm sorry to have to tell you that the jury is very much out on this too. We really don't have enough studies to give some definitive information. Now here's one study, a good study, which shows that there is a relationship between oral antioxidants and sperm quality and also pregnancy rates,
whereas the one here is expressed in kilometers per week. So we can see
the second one is a Cochrane review, but if you look at that, you can see that the numbers in it, although they're large numbers to start, they're very small numbers by the end of the study. So again, we need to have more work done. Now we get to the point
and
where,
what we were able to find
where
with
Professor
regards
Schlatt was
to this
asking,
relationship
can you
was that
give people antioxidants,
the
and do the
subjects that were
always remain antioxidants, or might they become pro-oxidants? And I think this is a very important point. We shouldn't be prescribing antioxidants to all men who come along to infertility clinics because of a number of the factors that we have here below. If people take over-the-counter medications from their local pharmacy or local chemist, there are all sorts of variations both in the constituents of the antioxidants and in their concentrations.
Had a
there are different combinations, different levels.
Normal
and
forms.
There's very little current
and what was clear is that
make
all
us
the
recommend
subjects
such things.
that
So we
actually
do
were
need
below the 4%
properly organised, large number, independent trials. But the question is, when are they going to be done? When are we going to have funding? And any of you in this room who have tried to get funding to do work on male infertility will empathise with me that it's extremely difficult to do. So what do we do in the meantime? There's a very good paper by John Aitken a couple of years ago talking about how we needed a little bit of oxidative stress. That oxidative stress in small amounts is physiological, and actually there are lots of sperm functions which won't
and they could find that
if there's not a little bit of free radical activity there to help them. But certainly, if in the proper levels and the proper constituents, the proper cofactors, there is an increase in both fertilization and pregnancy
rates.
So it
seems clear that high-load physical exercise, whether it's intensity or volume, may be detrimental
for example, there
for reproductive
large
function.
doses of vitamin C
and
selenium
also that the triathletes show worse parameters than physically active
subjects. The reason I say selenium and also
players.
vitamin E is because there's a very large study of 32,000 young, healthy
this
men
is a recent
done
study
in America.
in which we
it's
actually,
called the SELECT study, and what they found was there's actually an increase in both the incidence and the severity of prostate cancer for people who'd been on these antioxidants for a period of a year.
An increased number of
reason
round
for not
cells
using beta-carotene is it's strongly counterindicated as
and
a lung
also
cancer risk for
low
smokers.
total
But again, I wonder if
even though it was not
fertility clinics
significant, but it was
are aware of
in
these
the lower
things.
range of the spectrum.
And the other problem, and I do not
also,
wish to be sexist here, but men aren't awfully good at taking medications, and sometimes they forget to take them, and then they think, well, at the weekend, oh golly, I haven't taken them all week. My partner's going to be checking up on me, and they take a large dose of them, and that's really not a good idea. So I think we need to do proper studies and get proper results that we can actually explain to people that there's no such thing as a free lunch, so you really need to be sure that you need antioxidants. The only way you're going to know that is if you have high levels of oxidative stress, and those levels must be above a robust clinical threshold.
a lot of years. Many of them have actually started in the pre or peripubertal age, which obviously makes difficult for us to assess when these changes actually start taking place, because at that age is
and
not
it's also a waste of valuable female reproductive time, because if the man doesn't need antioxidants but he's told to go off and take
is exercise
a 3-month course of
bad for sperm
antioxidants
and
and come
oocyte
back,
quality?
well then that's 3 months
my
older
opinion
that
is
his
that
partner
actually
is,
the right
and
amount
maybe somewhere
of
else in the
exercise
waiting
is
list
good.
loop. So that's not a good idea.
And we have
either.
seen some of the later studies actually
a number
that they have tried to assess
studies,
the
a number
effect
of
in the
meta-analysis
clinical
about
IVF setting.
sperm DNA.
We have been
one
able
of the
to
things that
actually
Chris
see
Barrett,
that
probably well
moderate
known,
physical
maybe even in the
activity
room, I don't know,
is
well known
associated with
to
a
many of
small
you, would say
increase in
he's very
fecundability
pro
regardless of
sperm
body
DNA
mass
tests,
index.
but he thinks that there are
Physical
things that we need to
activity
do
might
before they
improve
become
fertility
routine.
among
The first is
overweight
to have
and obese
standardized
women,
methods, we talked
which
about
actually
a
they
moment
are
ago,
subgroup at
a rigorous
higher risk of
examination of their
infertility.
application, fully agree
And
with
also
that.
lean women
And
who
what tests are we going to
substitute
use and how are we going to
vigorous
use them?
physical
I'm
activity
not
with a
quite so
moderate physical
convinced that
activity
that is
may
a
also
big
improve
worry
their
for us, because I
fertility.
think most of these tests are going to be outsourced so that we're absolutely sure of
And
quality control. And I don't think there's something that
study also
routine
done,
labs are going to want to take on board, because they're expensive to set up and they're very, very time consuming. A paper came out, a review article in Reproductive Biomedicine Online, some of you may have seen it, just a couple of months ago, and I must say I was very disappointed with it, because it was just saying the same things as we've heard for the last 10 years. Oh, we need more studies, we need more randomized control trials, we need more evidence before we can use DNA tests. Well, I am absolutely 100% behind that, but what are we going to do in the meantime? We know the austerity that we're in at the moment. We know we're not going to have these randomized control trials. There's an absolute plethora of good cohort studies out there showing that that DNA tests are useful, and some saying that antioxidants are useful in protecting the next batch of sperm that are produced in the next 2 months. And so I wrote a response to this article, basically saying what I've just said now. So if any of you are interested in reading the facts and the opinions and a little bit more about it, then you can have a read at that. And this is really what I want to end with. We have a couple of choices. We can say we've got to wait, we've got to hang on until we are absolutely sure. And when is anyone ever absolutely sure that a test in infertility is going to be a useful one? DNA tests are non-invasive. It's not as if we're putting patients at high risk, but certainly we may be preventing them from having something which will be of benefit. So I leave that to each of you with your own conscience as to what you think we ought to do. In my opinion, we've much to gain and very little, if anything, to lose. So I'm a great supporter of them. Thank you for your attention.
Thank you very much. Now let's open for discussion.
Thank you very much for this outstanding presentation. We usually routinely do the DNA and the decantation test, either SASA, either an aniline blue, since more than 6 years in Paris. And what I am just not exactly agree with you is when you say that if you go to ICSI, you don't need to do it. We do the test and we try to improve the DNA before doing the ICSI if we can, by varicocele treatment or any antioxidant that we can. And that's just the difference with your...
Well, I'm delighted to hear you say that. I just didn't want to go over the top with this, but because I think IVF should move to ICSI, but if you're already doing ICSI. But I completely agree with you. I think it's a test that should be for everyone. So thank you for your support.
Congratulations for your presentation. You were running very fast, so
yes,
sometimes it was difficult to get your point. But anyway, I have your slide, so I can comment that. Yes. First point, can we come out from this room just establishing some points according to the literature, the one person experience and so on? First, you said that as long as the embryologists get motile sperm, we are sure that there is no DNA damage. Okay, so do we agree all on this? Because there is only one paper by John which showed that when he measured contemporarily a live sperm, DNA fragmentation, and adducts, 8 adducts. And they show that as long as you get a live sperm, the probability of having DNA fragmentation is only 5%.
Who is this paper by?
Yeah.
Who's
only 5% of a live sperm may have, according to his experience, may have a DNA fragmentation.
Yes.
So it's very low. It's quite low, but it's still there. I mean, you have any experience, because this is the only paper that I can find in the literature. And recently, we had just last week, we had a meeting in Taormina of the Italian Society of Endocrinology, where somebody was not did not agree with this data. So the question is, do you know of any other data, or do you agree on this data of John Aiken? Shall we stay there, or shall we just be skeptic about it first?
What I was saying about sperm motility having a relationship with DNA was simply to point out that it's the only parameter of a semen analysis which there is a relationship with. No, I don't think that there's a relationship between motility and low DNA damage. I don't think that that's a factor that we can take, and therefore if we have a motile sperm, it has low DNA damage. No, that is not the case. I'm surprised if that's what...
So you think that motile sperm can have higher DNA fragmentation?
Yes, it can.
In which percentage? You don't know, because John said 5%, and he showed, he's published in Journal Biochemistry. So
maybe we can add here data from Victoria's PhD thesis and from our lab. That if you use UVB, right, you can actually make the sperm completely immobile. And depending on what kind of UV you use, A or B, you can either make a nuclear DNA damage or a mitochondrial damage. So that shows that the two factors are completely independent. A well-swimming sperm doesn't automatically have a good DNA, and a bad swimming sperm doesn't automatically have bad DNA. So it can be completely independent. It depends on the testicular environment, more or less, because these two processes are...
But this is another point, because mitochondrial is more sensitive to oxidative damage than nuclear DNA.
Exactly. Once the nucleus DNA is done, I think it will be difficult to make.
So you cannot compare the two.
Right. But I think it's two independent variables which don't need to absolutely be correlating. So I think Sheena is right. In a very happily swimming sperm is not automatically a great sperm carrying great DNA.
So we must be a little bit skeptic about the John's data.
Yes.
Okay. Yeah. The second point about the threshold or the cutoff point of DNA damage, which we must or we may use for saying this is good, this is bad. I think we shouldn't consider the situation in this way, because you must take in consideration the oocyte quality. And now we don't have enough information. There is another course where they are just making the point where these studies are according to the biomarkers of oocyte quality.
Yes,
so I think
that's
so
important.
far we cannot put a threshold.
Well, I think we can, because the thresholds that we have here are the ones which were with eggs of whatever quality they were, but these are large numbers in these studies, and they have shown the relationship between sperm DNA damage and outcomes in terms of fertilization, embryo quality, and live
what
births.
Is the threshold, though? So
well,
according to you,
this is a really important point. The thresholds are different for DNA tests. Now, something else where we got completely confused.
Tunnel. Let's get tunnel.
I don't know about tunnel. That's the one I was saying. There, as far as I understand, there's not a clinical threshold at the moment, which is robust enough to be the same for every person who's using it. There is a threshold for the SCASA, which is 30%, which means that 30% of the sperm have damage and 70% don't, and that is the cutoff. Now and with us, it's 25%, but it's 25% damage per sperm, not. So we get damage in every sperm because our test is very sensitive, but it's an average, a mean of 25% per sperm is the cutoff that we have.
Last point is about treating a patient with antioxidant or not. As you know, this problem started in Italy because we had a factory in Italy which made carnitine, which was, so several trials was done that way. I think that so far we cannot say treat or not treat. Sometimes we are very desperate with the patient, so we give for desperation, treat with antioxidant for desperation, as we treat this patient when they have continuous prostatitis, urethritis, pelvic inflammation, we treat with antibiotics. But it's question of desperation, not question of treating on the basis of medicine evidence. So do you agree on that?
Yes, I do.
My attitude.
I do agree, but I certainly think that you need to do a test to see that the person has high oxidative stress before you treat at all. And then what treatment you use, again, we don't really know the very best one yet.
Jens Feder, thank you for your presentation. It's about also about treatment with antioxidants. There are a lot of specialists working with these things, maybe not so much in the andrology, but also in other audience. As I hear it, those people always distinguish between direct acting and indirect acting antioxidants. For example, the vitamins, for example, C vitamins, it is
scavengers.
It is very short-lived, and it burns out very fast after giving it, and it is in contrast to some of those plant extracts with pomegranate and what has been published in small studies with a modest but significant effect on semen quality, at least. So I think we have to distinguish between direct acting and indirect acting antioxidants in the future, and of course we need some large studies, and we have to be sure that we are not exposing our patients for damage. Yeah.
Yes, I agree entirely, and thank you. That's a very important point. I think as well as the action, we also have to bear in mind that vitamin C, for example, is hydrophilic, so it's in it's in watery fluids, whereas vitamin E is hydrophobic, so it is inclined to stay in the body for longer, and so they have a difference in that respect as well. In terms of vitamin C and vitamin E, they're scavengers, so they are picking up free radicals and neutralising them straight away. There are other things like zinc and selenium, which again were alluded to earlier on, which have different actions in terms of what they might do to protect or not protect DNA. So yes, you're absolutely right. It needs to be done. I'm not particularly optimistic that I'm going to come back next year and tell you that it has been done, or the following year.
I think I heard you say that you were going to comment about testicular sperm.
Yes.
Could you do that?
I could. One of the places which is a physiological place for sperm to be, but a very dangerous place for sperm to be, is the epididymis. And although the sperm has to move through the epididymis to acquire motility and to gain the disulfide bridges, which give it a lot more compaction of the DNA to protect the DNA, it's also a place where there's obstruction, inflammation, leukocytes, old sperm if the man hasn't ejaculated for a while, all sorts of enemies prowling around within the epididymis. And there's no doubt, and there are a number of papers from our group and from other groups that show if you have ejaculated sperm with high DNA damage, if you go to the testis of the same man, you can get testicular sperm which have much lower damage. And we actually had our first public comet baby a couple of weeks ago, because people obviously don't like to talk about this sort of thing. But this, just to give you an indication of a case study, this was a couple who had high DNA damage. They'd had ejaculated sperm, they'd had ICSI several times, no success. They changed their lifestyle, so there are two confounding factors here. They changed their lifestyle and also had ICSI with testicular sperm, they'd had 50% or 56% damage in the ejaculated sperm, they had 24% damage in the testicular sperm, and they have a healthy baby boy who they had all over the papers a couple of weeks ago. So it appears that if you have failed ICSI cycles with ejaculated sperm, that another option is to go to the testicular sperm from that man and see if you can get a sample which has lower level of DNA damage.
I have another question. You said in your presentation that it is not possible to treat all the patients with antioxidant, and before we have to test. In your opinion, what would be the best test to identify the damage induced by ROS? Because sperm DNA damage is a probable consequences, but not only, because it's also maybe due to a spermatogenesis defect.
Yeah. Well, the two tests that have been shown to have an oxidative cause for DNA damage are the SCASA and the COMET. So those are the tests which have an indication that the person has high levels of oxidative stress causing DNA damage.
Hi, Sheena. Thank you very much for your talk. Going back to the testicular sperm, if we have a high DNA fragmentation at the ejaculated sperm, do we assume that testicular sperm is better, or do we have to check that also before going on to ICSI?
No, I think that would be a very invasive thing to do. And I think most of the studies that have been published, and Greco and Tesserick are the people who've published on this, although there are small numbers, it is men who have had repeated failures with ICSI, because I don't think you want to go for testicular biopsy at the beginning. But if you've had repeated failures and the only clinical solution is for the man to have donor sperm, then in that case, I think he's quite keen to have one last try with testicular sperm and ICSI.
How about if instead of getting into the testes, have ejaculates many times and use sperm from the last ejaculate that had stayed for a very short period in the epididymis? That's very cheap and very easy to do, I guess.
All the work that's been done, I think, to show these DNA damage levels have been done on men who have produced semen samples according to WHO recommendations, so 2 days abstinence, between 2 and 5 days. I haven't seen any publications that have shown that DNA quality improves with daily ejaculates. But if that were the case, well, that would be very interesting.
In the sense that it doesn't stain the epididymis long.
Yes,
that's why I was wondering.
I understand your theory. Yeah.
Okay, thank you.
Makes sense.
Hi. I just you made a comment about suboptimal culture conditions, and that's why we should go to ICSI.
Yes.
Would it not? I'm not sure what you mean by suboptimal culture conditions, but would it not be better to improve conditions, maybe stick with IVF?
Well, yeah, it would, if that's what people are going to do. But I was thinking of the papers by Dumoulin, where they'd found that there actually was a different.
Have you looked at that paper closely? Because I think it's quite flawed.
Okay, that's fine, because there are 2 or 3 of those. But I think this is something that's going to be discussed here in ESHRA about culture conditions. And yes, I'm quite sure that is a possibility. There are people who are very pro that paper, and there are people who are very much against it. But it's just the idea that you can never have as good a culture condition as the oolemma. So that might be the best place for the sperm to be if it's got damage.
Okay.
Sheena, I think we're at the stage you will agree where we really need a great deal of principal component analysis. Where we need to put all these factors together, compensate for age. For example, in this crazy animal I showed this morning, we have 80% on an average basis, 80% fragmentation. We have 24 pups every time. So there is a female species with an ability to fix up.
Yes.
It must be, I'm sure, because there's just too few sperm that are normal. So the moral of the story is, I'm sure age and all those factors influence the ability of an oocyte to fix an egg. And there are multiple factors, and what I'm suggesting, and a lot of people have said this about semen analysis, and I think one of the reasons why it's not working well and why it's not very good, and I agree with you in IVF studies, is that we now need to put a lot of these parameters together, typically as bioplots, as biplots, I mean, in principal component analysis, and then show which are really the factors that relate. Don't you agree?
Yes, I do agree. I think one thing that possibly you're leading to is the idea that fidelity is not a good thing for the female, which is really very surprising, because if she is within a faithful couple, then she's going to have poorer sperm and she's going to have more work to do to actually create a healthy baby. But that's just being a bit facetious. Con.
I think, taking up on this, I think you hit the critical part about all of this. All of this is very good, but it's association. It's relationship. Until you get to the stage where you come up not only with principal component analysis, but you come up with causation, this is very nice, it's good, but it doesn't tell us the fundamentals. 25% of a threshold, that's 25% of sperm. Right, that means you have a 1 in 4 chance that you're not going to do it, but you have a 3 in 4 chance of hitting a correct sperm. So, for the analysis to be done, it can't be a meta-analysis. You're looking at what a few studies have looked at and come up with their results, and then you say, if their results are correct, therefore overall the results are correct. What you need, what are the chances by luck of being able to come up with these results? This is why it's vital that this thing that started in Florence has to be done. The argument of we have nothing to lose is personally flippant, because apart from providing a diagnosis, we can't provide them with the therapy, we can't provide them with the means of being able to get on, and all we are doing is providing a smokescreen. When the antioxidant stuff works, if it works, great. Great. But to come up to someone and say, you know what, we found a test and you've got 50% chance, go and have major surgery. Go and have a testicular biopsy. I think that's very foolhardy.
Can I just go back to the point you're making? I think you misunderstood the 25%. Were you saying that 25% threshold meant that a quarter of the sperm were damaged? Is that what you said?
According to your, let's go back to the first Luke Simon paper. You've got less than 40%, correct? Now, then you swap and you go to less than 25%. So you're saying in one, a percentage of the population. In the other, you are stating what you perceive to be the extent of damage within a single sperm, correct?
No, not correct. In terms of the 25%, that is the level of the damage, the mean damage in the sperm.
In how many sperm?
In all the sperm that were measured.
In all of them. So every single sperm has got 25% damage.
Correct. That's the same. It's the same in both of them. It's not different.
Well, it's not, because you've quoted 40% in Luke Simon's paper.
No.
Yes. Look up your own slide.
No, hang on, Con. I know exactly what's in my slides. 25% is the cutoff point for infertility. In that, what I was saying was this was a cutoff. If you had more than 25% damage, then you were within the infertile range.
In terms of
the yes, the average amount per sperm. They're all per sperm. And secondly, it was whether or not you would be successful with IVF, and that was where the 25 to 50% came, between whether you would use IVF or whether you would use ICSI. So that was the prognostic aspect of the test, as opposed to the diagnostic aspect.
It still doesn't answer the question.
Perhaps I can raise another question. We really treated you hard here, Gina. I screened through all the abstracts from the andrology submissions to ESHRE. There were about 300. I think at least half of them dealt with oxidative damage.
Yeah.
And I perfectly agree with you that, let's say, many of these scientific works were observations on very limited number of sperm, very limited of patients. So we will not get really good evidence from all these attempts. So you made a few very important marks in that you say, look, let's get some more data out. But there's a lot of people in the room which go back home tomorrow into the andrology labs, and they may be able to do some good data. That not yet another 150 abstracts next year, we will say, okay, they're not really valid. But you made a few suggestions what they can do. So what borrow that we get better evidence in a year or two without huge studies, which would cost a huge amount of money? We can't do that. Most of the people in the room here would like to add data, but they can't do it. So what would be good data? Do we have to send them the samples to SCASA labs? Do we buy Halo chips to do it ourselves? Do we implement a collaboration with another group which can help us to do some of these techniques? This is, I think, a very important message today, that eventually we can do nothing, but then you can also say that to get an improvement of all these poor data situation which we have.
Yeah. Well, thank you. I think you're saying a couple of things. One is that a whole lot more small studies actually will just end up with what we've got at the moment. Sorry. So if we do a lot of small studies, I don't think I have a message to individual labs that this is what you can do in the next year, because I don't think the information's there. I certainly agree with Con that we need to have...
I would agree, and especially to bring